We've seen a lot of innovation in this space now. We still need more innovation, but fortunately we've had some advances. And if we now think about, let's say, the antibody drug conjugates, and really it was the original ASCENT trial in the second-line space and beyond, where we saw Sacituzumab Govitecan enter the TNBC treatment paradigm. Anna, how has that changed your treatment approach, or how did that change your treatment approach and patient experience?
Yeah. So with the ASCENT clinical trial data, we really saw a shift, right, in the pre-treated setting with these antibody drug conjugate type therapies that are able to deliver cytotoxic chemotherapy at higher doses in a more targeted manner and significantly improving outcomes, not just progression-free, but also overall survival in the pre-treated metastatic TNBC setting. And so with SG, also we've seen data for trastuzumab deruxtecan from an exploratory analysis in the about 40% of patients who have HER2 low triple-negative breast cancer, really change in how we think about delivery of therapies for patients in the pre-treated metastatic setting. And I think particularly with the data both for PFS and OS from ASCENT, a shift in how we think about cytotoxic therapies in second line and beyond. And so here for the patient who has progressed on first line therapy, whether that be standard chemotherapy or chemo plus immunotherapy for those patients with PD-L1 positive tumors, now the standard has been to think about Sacituzumab Govitecan in that setting.
Absolutely. I resonate with your point that I think ASCENT really was practice changing in terms of now making Sacituzumab the standard of care in the second line setting. But back to your point, Joyce, about using our best treatments up front, of course, the space has evolved again, and we now have multiple trials in the first line setting. But let me start with a general question. We're all involved in designing and executing clinical trials. How do you design a first line trial when you already have an approved therapy, when you want to test a therapy that you already have approved in a subsequent line of therapy? That's a bit of a challenge, isn't it?
It is, and particularly when it impacts survival.
Yes.
And that was the ASCENT 04 trial was the ASCENT trial was very mind-opening because the chemotherapy later line was extremely poor. It had very, very low, like the PFS was like 1.5 months and the OS was 6 months. And so the survival went from 6 months to a year with SG. So that was really, really huge. It really spoke to the non-cross resistance of SG and also, as you said, to the better drug delivery as well. So now you're bringing that agent, for example, which is already approved in the later line setting, into the first line setting. I think people are very happy to use it in the first line setting because they want the biggest, effectiveness they possibly can.